Hi, my name is Andrew Umrod and a warm welcome to CPD-Me. Here at CPD-Me, at the heart of what we do is build a CPD portfolio that is fit for audit, interview, or just to show off your learning and development that you've achieved over the years. So please sit back, relax, enjoy this fabulous webinar, and we'll tell you all about the great benefits of joining CPD-Me at the end of this broadcast.
Okay, so my name's Anna, and I'm currently working as an education fellow at Newham University Hospital in London, which is part of Barts Health NHS Trust. And as during that role, I have been involved in some simulation around having difficult conversations and breaking bad news over the phone. And leading on from that, my colleagues and I wrote an article for the Emergency Medicine Journal, the EMJ, and that's why I'm talking to you about this subject this evening. I'm really looking forward to seeing your questions. There's a lot of you, so I'm not sure I'm going to be able to see everything that's happening on the chat, but if you do have a question, then please do put it in the question and answer box, or you can tweet me at Dr. Collini, and then my email address is there as well if anyone wants to get in contact after the talk. So this is a little bit of a summary of what I'm going to talk about this evening. So obviously, with the COVID-19 pandemic, the visitors to our hospitals have been significantly limited. And we were finding early on in the pandemic that we were having to have conversations over the phone that we did not expect to have over the phone. And it was an issue because this was more difficult and no one had had any training in this. So my colleagues and I, so Helen Parker, who's an emergency medicine consultant and the simulation lead at Newham, and Amy Oliver, who works for Role Plays for Training, which is a drama-based training company, designed a simulation session, which we've been running ever since kind of March, April last year. And I'm going to talk through a little bit about what we did. And then finally, I'm going to talk through what we've learned, both from running that session and the review of the literature that we've done. So I'm going to talk, first of all, a little bit about breaking bad news in general, not specific to over the phone. And it might sound like a strange question, what is bad news? But we need to remember that bad news is subjective and it depends on the individual. So, for example, someone who has had an epileptic fit and is told that they cannot drive, it has different implications for someone who lives in London, doesn't drive, has access to excellent public transport, compared to a lorry driver who relies on driving for their income. While the news might not be great for either of them, the impact is different. But obviously, there is some news that is universally accepted as bad, particularly things like critical illness, death, or dying. And that's the main thing that I'm going to talk about in this session. So why is it so difficult to deliver bad news? And I think we have to remember that each person who's receiving that news, whether it's face-to-face or at the end of a phone, has unique cultural and personal preferences for how they want information to be delivered. And it's impossible for us to know that beforehand. And so we kind of just have to do our best, really. But we're never going to get it right all of the time for everyone. And then obviously it provokes negative emotions in us as well as the people that we're talking to. It can make us feel sad that we're having to give this bad news. It can make us feel guilty that we should have been doing more. And then this has come out in our simulation sessions, that often there's a feeling of failure, that if someone is dying or they've died, that we have somehow failed them, when actually dying and death is a natural part of life. I think there's a lot of fear around delivering bad news as well. So we're fearful of not doing it well. We're fearful of extinguishing hope. We're fearful of being wrong. What about if we tell someone that their relative is dying and then they recover? And I think often we're fearful of the emotional response that we might get. And are we going to be able to deal with that response? So there are all these things swirling around, and these are just made so much harder over the phone. So if we think specifically about breaking bad news over the phone, we have all of the usual difficulties that I've just spoken about, but also it's relatively unfamiliar. I know, unfortunately, many of us have become increasingly familiar with this over the past year. But actually, we've generally not had any training in this area, because all of our previous training has told us that we should have these conversations face to face, because that's much preferable to having them over the phone. And we've got limited experience to draw on. Obviously, the biggest loss is the loss of all that non-verbal communication and care. And I think about the loss of the non-verbal warning shots that we have. So being shown into a quiet room, the expression on someone's face as they show you in there, the offer to make a cup of tea, all those things are non-verbal warning shots that are lost when we have these conversations over the phone. When we are communicating, we obviously don't have our body language, our facial expression to express our compassion and our empathy. And so we have to use language to do that. And that's something that maybe we're not so practiced at, and we've maybe not thought about so much. And I've put in there about the care that we give. And it's things like, after you've broken bad news, to be able to go and make them a cup of tea and bring it into them to show that you care. Knowing that someone is in a safe place with, even if they don't have any friends or family around them, they've got us as professionals who are there to offer some support. And finally, I think another reason that's making it very difficult for us as healthcare professionals to break bad news over the phone is that it's very distressing to see patients very unwell or dying without their loved ones present. And I think we need to acknowledge that. So taking all of that into consideration, we think that there's a need for specific training in this area. So, what kind of educational interventions are there for breaking bad news? This comes from the review of the literature that I did for the EMJ article that we published. So all of the literature that I found that I felt was relevant was based around face-to-face breaking bad news, but I think that it can be applied to doing this over the phone as well. So most educational interventions were based around a framework, and I'm going to talk a little bit about frameworks in a moment. Most are mixed methods, so mini lectures, workshops, small group discussions. There's an emphasis on empathetic and compassionate communication. And the majority, like we did, use simulation in some form, whether that's role play or whether that's more immersive simulation. And so I'm going to talk a little bit now about how the rationale for using simulation. So simulation is seen as a safe and ethical way for people to practice doing things that may be risky on people that can't get hurt. So in our case, we used actors. People are able to get feedback, which is impossible or very difficult to get in real life. And I'll talk through a little bit about how we did that. And although it's safe for the actor, because they're an actor rather than a real patient or relative, we do have to remember maintaining the psychological safety of the participants that we have in these educational sessions. These are really emotive subjects, and we need to make sure that we look after our participants who are coming along to these educational sessions. And again, I'll talk a little bit more about that in a moment. There's good theoretical underpinnings for using simulation. I've included one here, which is Kolb's reflective cycle. So obviously the concrete experience, they go through the simulation scenario. We then reflect on the experience altogether, discussing it in the debrief and getting some feedback from the actor. And then finally, we help to the participants to draw out the learning. So learning from the experience, the abstract conceptualization phase. And finally, we try and prepare them for the active experimentation phase where they can try out what they've learned. So, as I said, most of the educational interventions use frameworks. And those of you who have attended training in breaking bad news probably will have been taught about a framework. And there is some evidence for their use, but it is limited by the methodology. And there are good ethical and logistical reasons why this is limited, but I think it's important to keep in mind. Usually, the way that these frameworks have been assessed to see if they are effective is that participants have been trained in the use of the framework, and then they have a simulated scenario and people are assessed on how well they've used the framework. So they're not really being assessed on how well they have the conversation necessarily. They're being assessed on how well they use the framework. And while these frameworks are based on the literature around what patients want, we've not really tested them, the actual effects on patients or their families, but that's obviously difficult. The most commonly used one is spikes, but there are lots of them out there, and I've decided in this presentation not to go through all the different frameworks. It's been shown that using a framework can increase confidence. And that's a really important positive for using frameworks in this context. Because if you think back to the beginning of the presentation, if there's anything that we can do to help reduce that fear around having these conversations, that is a good thing. However, having done the simulation sessions, I've facilitated many of these now, I can see that sometimes using these frameworks seems to inhibit a natural conversation, and people try and go through the framework in a stepwise manner when actually they just need to have a human conversation with a person rather than going through the steps of a framework. So our conclusion is that we think they're probably useful in initial training for people who've not had much experience, to give them some kind of structure to how they might approach these conversations. But I think it must be explicit that these frameworks aren't boxes to be ticked, but should be used in a flexible manner. So the training that we did was generally with staff who had had training in breaking bad news or had had experience in doing it. And so we didn't advocate a particular framework in our training, but just emphasized the human aspect of the conversations, clarity and language, honesty, empathy, rather than a specific framework. However, if I was to recommend a framework for breaking bad news over the phone, it would definitely be the e-learning for health framework, discussion of unwelcome news during COVID-19 pandemic. It was actually published at the end of March last year. And when I talk through some advice for making these calls, a lot of it is based around this framework, as well as the learning from our simulation sessions. So what did we do? We had small groups of participants, and these have been varying staff members. So we've had senior registrars, we've had consultants, we've had SHOs, foundation doctors, and nursing staff as well. We start the session with an introduction where we explain the rationale for doing the session. We emphasize the usual ground rules of simulation, and this goes back to what I was talking about psychological safety, that what happens in the simulation should stay confidential, that we don't discuss it outside, that it's not a test or an assessment, but just a place where we can practice and learn. And finally, and I think this is so important in this context, is that we acknowledge that this is a really emotive subject, and that we know that some of the things that we're going to talk about will touch on people's personal lives as well as their professional lives. And we give people permission that if they feel like they need a timeout, if they need to stop at any point, or they decide they can't do something, that is absolutely fine. And we have had that experience where someone has volunteered and then heard the scenario and said, actually, I can't do that. And we have acknowledged that is obviously absolutely fine. We then give a briefing about a case, and we have adapted this for use in different settings. So depending on the participants that you have, for example, we have done pediatric cases, we have done DNA CPR decisions, but the case that we use most commonly is a patient with coronavirus. So someone who comes into the emergency department and requires CPAP, deteriorates on CPAP, and is going to need intubation and ventilation. And the first call is to inform the patient's wife that they need to be intubated and ventilated. So we ask for a volunteer, and that volunteer makes a phone call to an actor who's at home. We usually use our own mobile phones for this. We put it on speakerphone, and so all the participants can hear both sides of the call. The actor then gives some feedback. As I said earlier, we use a company called Role Plays for Training, which is a drama-based training company. And all their actors are trained in giving feedback in these kind of scenarios. And this part of the session has been really, really important and a bit eye-opening for me, actually, because the actors have no medical training. And so their feedback is more genuine and I think carries more weight than if it was a member of the medical team as faculty. It's small things like the non-technical language that we use that maybe means something else to someone medical. So, for example, that phrase, "oh, they're really sick," I think that means something different to another doctor, for example, than it does to a member of the public. They don't know anything about these frameworks that we have been taught to use, and so their feedback is genuine rather than coloured by all that knowledge. We then have a debrief where we discuss what's happened in the phone call, but we also draw in the experiences that people have had in their day-to-day practice, and go through that reflective cycle that I talked about. So thinking about their own experiences and how they might use what they've learnt, and they learn from each other. So suggesting phrases, for example. We then have another 1 or 2 phone calls, so 2 to 3 phone calls in total, as the scenario progresses. So in the example I gave you, the patient whose name is usually Michael, Michael deteriorates on ventilation. Despite maximal therapy and intensive care, he's deteriorating and he's expected to die. So the second phone call is to tell his wife, usually Amy, that he's expected to die. And then the final conversation is that Mike has died. So I'm going to talk through a little bit about what we've learned and a little bit from the framework that I mentioned earlier from e-learning for health, about how you might think about going about making these calls. So firstly, the preparation. So what is the main message of your call? What key thing do you want them to take away from that phone call? And think about whether you're just giving information or whether you need to get information. And as I said earlier, you might want to think through some phrases for how you're going to say that. And I'll talk a little bit more about that in a moment as well. Gather information. So think about what people might want to know. So check before you call, are the relatives going to be able to visit the patient who's in hospital? Do you have the number for the bereavement office if the patient has died? Make sure you know what the next steps are. And then think about the environment. Although you're obviously not going to be taking someone into a physical environment, the same things are still important. You don't want to be interrupted. So can you give your bleep to someone? Can you go somewhere quiet where you can concentrate on this call? This isn't the kind of, if you're breaking bad news, you don't want to be sat at a busy nurse's station. where you're going to be interrupted. So when you start the call, introduce yourself, check who they are and if they're able to talk. This is, again, one of the real difficulties around having these conversations, is that you might call when someone is driving or in the supermarket or in the middle of giving their child a bath. So checking if they're able to talk at that moment is really important. Tell them who you are, who you're calling about, and check the relationship. And then check their understanding of what's happened up to this point. Now, this is something that is mentioned in most of the frameworks that have been published. But what we've found in the simulations is all of this beginning of the call can be really, really difficult, because if you are a relative and you have someone that you care about in the hospital, when you get a phone call and you see that no caller ID number come up and you go to answer the phone, I think lots of people will fear the worst, that things have got worse or that they might have died. And so if you have someone who's saying, how are they? I just want to know how they are. And then you say, I just want to check what you know already. It can just feel a bit like, some of the actors have said, it feels like you're testing them. And so I think this has to be a little bit flexible, and you have to respond to the person in a human manner. So you might want to say something like, I've just come from their bedside. I'm going to give you an update. But you can do things like actually explain why you're checking their understanding. So I think it would be really helpful for me to know where you're up to, so I can make sure that I tell you the right information, for example. But I think this part has been the part that is most difficult in some ways to get that right. So when you come to actually giving the bad news, describe some of the things that are wrong with the patient and how these have progressed. And this acts as a warning shot. Tell them the bad news clearly, and remember to pause and allow silence for them to take the information in. Silences are really, really difficult over the phone and can feel really uncomfortable. And some of the phrases that we've found helpful in this kind of situation is things like just saying, I'm so sorry, or I'm here when you're ready to talk, to remind them that you're there and check that they've not been cut off, for example. Finally, closing the call. Try and offer something that might provide some comfort. So that might be, we're doing absolutely everything that we can, or I'm going to try and organise a video call for you later. If the patient has sadly died, then often something that people get some comfort from is that they didn't die by themselves. So if you can say that a member of staff was with them, or that they were comfortable at the end, is something that might provide some comfort for people. Continue to express compassion, and you can be honest about how difficult this is. Yeah, I know this is so awful. I'm sorry to have to do this over the phone. All those expressions of compassion and empathy are really important, because we can't express it with our face and our body and our gestures. Cups of tea in the British way. make sure that you discuss what happens next. So whether that's you're going to call them tomorrow, or what happens with the logistics of bereavement. And then finally, ask if they have any questions for you and answer them if they do, and remind them of your name and say goodbye. So as I said, that's mainly from the framework. I'm going to talk about a few other things that have come out that we think have been really important. So patients and their relatives, the really key things that people want are clarity and care with language. So the usual advice applies about not using jargon, make it simple and use non-medical language. And we found that sometimes people would almost accidentally use casual language that the actors found quite difficult to hear. So things like, we're going to pop in a tube, when people were being intubated. And remember that as healthcare professionals, we do have that different language, and it takes care to translate our medical language into something that lay people will understand. Don't use euphemisms. So we have found that when it comes to talking about telling relatives that a patient has died, people will still very often use passed away rather than death or died. And we've talked a lot about why that might be. And people talk about softening the blow. It just sounds kinder to say passed away rather than died. But what we usually then come to discuss is the risk of misunderstanding. And where I work at Newham, there is a large proportion of people whose English isn't their first language, and they might not understand that euphemism. And this isn't something that we don't want people to understand. We need people to understand this kind of news. And we talked about that actually using a euphemism such as passed away is actually probably more for us who are breaking the news, to make us feel better rather than making the person at the other end of the phone feel better. Honesty is really important. And this often comes out in that middle conversation that I talked about, where Mike is expected to die and we have to tell the family this news. And I think this is probably the most difficult conversation. It's the one that people struggle with the most. And you can see people not wanting to give the news, and they talk in, they say things like, oh, he's deteriorated, or we're doing our best, but he's not getting better. But they almost can't bring themselves to say that he might die. And when we've talked about why this might be, often it's because people don't want to give that news. They don't want to say something that is going to be absolutely devastating for the person on the other end of the phone. But actually, what we've decided through our discussions is that and what the actors have said, it's kinder to be more upfront with that kind of news, rather than giving lots and lots of warning shots and people trying to work it out from themselves and then not feeling clear. People want clarity. The phrase that I really like in that kind of situation, where we're expecting that they're going to die, comes from the wonderful Catherine Mannix, who's a palliative care consultant and has written a lot about death and dying and how we talk about it. And she uses the phrase sick enough to die. And I think, if again, we think back right to the beginning of this presentation and that fear of getting it wrong. And we don't want to say they're dying, they're definitely going to die, when everything might point that way, but what if we're wrong? What about that tiny, weeny chance that we're wrong? But actually sick enough to die kind of covers that we think they're unwell enough that they might die. We have also discussed how rehearsing phrases such as that, sick enough to die phrase, or how you're going to break the news that someone has died, rehearsing that phrase might be helpful in that situation. When it's something that you really, really don't want to say, having a phrase that expresses that ready makes that process easier. And finally, the most important thing that we have found in these conversations is just to have empathy and compassion. And each person will find their own way of what they feel comfortable saying to express that. But I think that we have to be aware that, as I've said before, and I make no apology for saying it again because I think it's so important, that we have to express this in our words rather than our body language and facial expressions. So we may need to say these things more than we would do normally. I'm so sorry. I wish things were different. I wish I didn't have to give you this news. It's such an awful situation. I'm so sorry that you can't be here. All of those things are really, really important for people to hear. And finally, the other thing that has come out of this for us is that it has created space for healthcare professionals to stop and think, and to have a space to share the experiences that they have had, and to express and normalize the emotions that come along with these. These are really, really difficult times. And it's okay to find these conversations really difficult and really upsetting. And we have found that having that space and that peer support has been really, really important for the people who've come to our sessions. So that concludes what I've got to say. So in summary, breaking bad news over the phone is hard. Healthcare professionals need to be supported to have clear, honest, empathetic and human conversations. And there's a need for specific training in this area. Thank you very much.
Hi, I'm Stephanie from CPD.me, and welcome to our webinars. Taking part in our great CPD webinars is an excellent way to learn new skills and knowledge in an informal way, either whilst at work, relaxing at home, or maybe enjoying some downtime in the park. Our webinars are designed to support our learning community, to work and learn in a relaxed and informal environment. And the great thing is, if you're a member of CPD.me, you can replay and watch these back whenever you like. Registering for a webinar allows you to attend the live event and interact with other viewers online, sharing both learning and links. Don't worry if you can't make the live broadcast because you're running out of time or get a late job. Simply register and we'll email you a fully edited copy of the broadcast the following day. Members of CPD.me receive a free CPD certificate for watching both live broadcasts as well as watching previous webinars. Premium members also have access to a personal CPD dashboard that contains priority booking for all our live webinars, plus over 500 CPD webinars and seminars on demand to watch whenever you choose, with automated CPD certificates. You can always purchase a CPD certificate if you're not a member, but it is more beneficial for you to join CPD Me and take advantage of all the benefits. One great feature of membership is that you won't have to pay for every certificate, and we will automatically add a copy into a professionally formatted CPD portfolio, accessible via your CPD dashboard for all our mobile apps. Join today, and we'll backdate any webinars that you've watched within the last 14 days. Now is the time to take charge of your CPD. Now is the time to join CPD Me.